Today we're going to be focusing our presentation on the hospice patient that goes in the general inpatient for symptom management. And then we'll also take a look at respite care, which is another very common inpatient thing that we do within hospice. As you all know, there are, those of you that work in hospice, there are 4 levels of care. Routine home care, general inpatient care, respite care, and continuous care. We will focus on the other levels of care in different presentations. Today is just going to be strictly GIP and respite. So our objectives, we're going to start out first of all talking about the Medicare regulations for both of those. Most hospices, if not all, are Medicare certified, state licensed, either accredited by CHAP or ACHC or Joint Commission. So we're going to focus on all of those regulations and standards so that you have a clear understanding of what's expected, especially if you do work in hospice. For all of our long-term care attendees today that work in skilled nursing homes, this is a very important presentation for you as well, because a lot of places are contracted with nursing homes where they place patients on GIP and respite. And then for those of us that work in other areas, maybe in consulting or whatever, it's important for you to understand the standards from all the regulatory bodies. We'll also identify patient eligibility, which has pretty much stayed the same throughout the hospice Medicare benefit when it was designed in I think it was 1986. And then in 2008, when they came out with new Medicare guidelines, there were a couple of different things that changed. So we'll definitely talk about those. There are some barriers to GIP and respite that you must be aware of so that you don't fall into the category of not being compliant. And then we'll share some scenarios, some actual live cases of people that were either GIP or respite in different facilities and what some of those scenarios are, so that in case you've ever come across those, you'll know how to deal with that. So Medicare concerns in 2016 were basically the same concerns in 2018. So the stats are just maybe 1% or 2% different, but this is when it first came out in 2016, and then I updated it for today. So the hospice's inappropriateness billing, according to CMS or Medicare, was $250 million for GIP in 2018. And you're probably thinking, you know, what could possibly be inappropriate billing? Well, the majority of those were in actual IPU settings, freestanding inpatient units, about 67% of those. And actually those had to do with people that really did not meet criteria for GIP, but were placed in GIP for a number of different reasons. That was the majority of the inappropriate billing. And then providers were also not offering a full range of services. We tend to think of inappropriate GIP or too many people, you know, inappropriate diagnoses, not meeting the criteria, but there's also what I consider to be underutilization, which is something that Medicare has been looking at very seriously within the last 3 years. Those are the providers all over the country that are not offering the beneficiary GIP, which clearly they qualify for it, but they're not providing it. They're keeping them in their own home. So we'll talk about how that affects us in a few minutes. So not all providers are documenting the support for it. Now, what I mean by that is a patient can qualify for GIP and respite for that matter, and go into a freestanding unit or a Medicare certified facility, skilled facility, and they may very well meet the criteria for GIP, which the criteria is kind of widespread, and we'll talk about that as we go through the presentation. But what happens when they go in and then Medicare reviews those records in 6 months, a year from now, and there's nothing in the nurse's notes or the physician attestation statements or in any notes whatsoever supporting the fact that we put them in GIP. So it's very important that you document the reason they're going GIP, and not just you putting them there, but the people that are caring for them. So those people that work in skilled nursing facilities, the nurses specifically, also have to mirror your documentation on a daily basis and talk about what you're doing for discharge planning the minute they enter GIP. So the reasons listed were not meeting the criteria. So 67% of those were not meeting the criteria for GIP. So a third of those patients had a length of stay greater than 5 days, which is not necessarily a problem unless you can't substantiate that. 11% had 10 days or more, which can also is acceptable provided that the documentation supports it. But 71% of GIP had started on the exact start of care date. Now, that doesn't mean that when someone signs on to hospice that they don't qualify for GIP. They very well might qualify. Maybe there's titration of medication or some new wounds that have symptoms to go with it, and they just can't be managed at home. But there also were quite a few patients that went in right out of the hospital that really could have been managed at home. So Medicare looks at all of those very carefully. So the review for all GIP stays focuses on hospices that have long length of stay. So the patients that are on for an extended period of time, the Alzheimer's patients, the patients that are in group homes, assisted livings, they typically are on service for a long time. And if they do go GIP, Medicare is very particular about what are the reasons that you did that. Is it something that clearly meets the criteria? And they look at hospices that have no GIP at all for a whole year through the cap period. So cap period is like November 1st till October 31st. So did anyone not have GIP or respite? Because remember, we must be able to offer all 4 levels of care. And then we look at those GIP patients that had no symptoms at all, but were being calibrated at home. So most of the time, or not most of the time, but several times with our 3 programs, I just had a discussion just last week with one of them about a patient that was at home having pain issues, being switched from the morphine over to methadone. Methadone is one of those reasons that I would consider you're going to be titrating, you're going to be looking at a small dose going up to 10 milligrams, or maybe, looking at your morphine and titrating that off and going into 2 milligrams of methadone. That would be something that I would look at, because those symptoms typically can get out of control, and you want to make sure that you're calibrating it carefully. So we look at hospices that are doing GIP in a SNF. Remember, in order to put a patient in GIP in a SNF, it must be a Medicare SNF, but licensed SNF. You must also have a contract with them to be able to do that. And you must have also gone into that facility and taught those nurses, physicians, aides, caregivers, how to care for a patient that's on GIP. Half of the charts reviewed by the OIG did not have unmanaged symptoms. So I talked a little bit about that in the beginning, about the fact that if you put someone on GIP, the OIG, which is the Office of Inspector General, which does all the audits for Medicare agencies, and look specifically for Medicare fraud, will be looking to make sure that those patients did have symptoms that you are managing and titrating medications on very carefully. And 85% of those, according to the OIG, did not meet criteria. So typically the way we work it at our hospice company is naturally the nurse would identify, the physician would identify a patient for GIP. They must be symptoms that cannot be managed at home. They would call their supervisor, clinical director specifically, and they would talk about what the criteria is and if the patient meets the criteria. Then we would call the facility, or we do have an inpatient unit that we are contracted with. We would call them to see if they have a bed, and then we would arrange for transportation to get the patient from home into the facility for their GIP stay. Typically it's short term, maybe 5 to 7 days. It can be longer, and what you must remember to do though is if you go longer, that you are documenting what the reasons are. So GIP is defined as short-term care provided directly by the hospice, either in their own IPU. There's several hospices throughout the country that have their own unit. They must be staffed 24/7 with an RN in charge at all 3 shifts, or whatever shifts you have. You must be able to provide a home-like environment so that the patient has things that are familiar to them, surroundings. It looks more like a home than it does a hospital setting. And it must be in a Medicare certified facility. And there are specific state and federal regulations for an IPU. And if you do have an IPU, hopefully you are following your regulations to a T. With Arizona Care Hospice, we do both. We do have an IPU that we are contracted with that we send patients to in the Phoenix area. We also have contracts with multiple facilities in the Payson area, Phoenix Metro, Maricopa County, and also up north in Prescott Valley area. So GIP, which is called General Inpatient Care, is provided to a patient that has pain or symptoms that cannot be managed in the setting that they are in, specifically in their own home. Now, a patient in a nursing home that we take care of that is on hospice, on routine home care, can be flipped to a GIP bed, provided that they meet the criteria for hospice, and then we have a contract with that facility. So it may be used for procedures necessary for pain control and symptom management that cannot be performed in a home setting. It's not equivalent to a hospital setting, but it is equivalent to the home setting. So things like maybe they have symptoms, liver failure, have to have a paracentesis. We don't do those in the home unless they have a port implanted, and they have to be watched carefully for vital signs afterwards, thoracentesis, chest tubes, IVs, all kinds of stuff that have symptoms. Then we would certainly be able to put them in a GIP setting, because we cannot do that in a home setting. The delivery of pain medication has to require a skilled nurse. Calibration of medication, frequent tubing changes, frequent adjustment to the complexity and the nature of the delivery of the medication. So whenever we are doing IV titration, dilaudid, anything on a pump, medications that require titration, methadone, which is a very controversial drug when you put somebody on it right away. Also looking at the complexity of the different kinds of things, but it must require a skilled nurse. And the documentation for that, the reason has to be every day, why the patient's going in for skilled nursing and medication changes, why it can't be done in the home setting, and then the nurses in the inpatient unit or in the facility also have to document the same thing. Why they're titrating and how they're doing it, the communication that they're having with the hospice. Hospice nurses are the professional managers of care. It is for that reason that we recommend that the hospice staff, specifically the nurse case manager, visit the facility at least on a daily basis so that she or he is in collaboration with the facility and the GIP staff. So frequent evaluation by an RN only. We certainly, encourage chaplains, social workers, aides to go in and see our patients in the different settings. The patient is used to you coming into their home, so seeing a familiar face is always a good thing to do. And aggressive treatment to control the pain is something that we would want you to use GIP for, because not everyone reacts to pain, the same way. So sometimes patients do very well on PO medications, or if you can't give it by mouth, we do it sublingual or rectally, whatever it might be. But if you have to have frequent medication adjustments, it's one of the primary reasons that I would encourage you to utilize the benefit, the GIP benefit. Sudden deterioration in care requires frequent nursing observations. So these are some of the other reasons that GIP is acceptable according to Medicare guidelines, and that would be the following. Uncontrolled nausea and vomiting. Perhaps you cannot get it controlled in the home. You're doing things like Haldol, you're doing Compazine, you're doing Phenergan, you're doing, all kinds of different things to try to control it. And so maybe you need to use Zofran and the patient's never been on it, so you need to move them to the unit to try to get that stabilized. Pathological fractures, movement, being able to care for them, breakdown of skin. Maybe the family needs some time to get the home ready, or a specialty bed needs to go in. All kinds of things, we need to move them GIP for a while. Respiratory distress that becomes unmanageable, which is one of the biggest ones that I've seen throughout my career, is the COPD people, CHF people that are on different diuretics. Sometimes have difficulty with oxygenation. Their pulse oximetry drops, in the low 80s, and then you need to titrate and make sure their oxygen is managed correctly. Families will typically really stress out with respiratory distress. And what we want to do is prevent them from 911ing their loved one to the hospital. When people can't breathe, that is the most common reason we see that people go to the hospital. But if we could manage those people at home, that's great. If we can't, we can always GIP them to get their respiratory situation under control. Uncontrollable bleeding, especially varicosities, liver failure patients, see lots of those people that have a hard time, with bleeding issues. Traction, frequent movement requiring, more than one person. Severe agitation, delirium, anxiety, and depression, so severe that it requires several staff members to get that under control. Lots of questions come to my office almost every month about a patient that has behavioral issues. Can they go GIP? Because the facility doesn't want to deal with the fact that someone's got behavioral issues. And we'll talk about that more when we do a scenario, but the behavioral issues can be if they have symptoms to go with it that need to be controlled, and they can't be controlled in the home environment. So we'll mention that a little bit at the end and give you a scenario about that. Wounds used to be fine. If you had wounds and you needed to go in the GIP level of care, you could. It's changed somewhat. It must require frequent treatments. Medications have to go with it that are unmanageable. Things like hemorrhage, pain, and infection. So severe wounds that have a lot of pain, you're titrating medication to get them right. They're bleeding. You have an infection, you have to use some isolation precautions. Things of that nature would require you to really substantiate documentation on both ends, from the facility side and also from the hospice nursing side. If in a SNF, they must have an RN 24/7. So in 2008, one of the things that changed was respite care didn't require an RN anymore, but a SNF, an RN must be in there 24/7. Same thing if you have a freestanding inpatient unit, and you must make sure that you have sufficient staff to cover every shift. And that includes every inpatient unit across the country. That's a federal mandate. There is no specific regulation that says that hospices have to make daily visits, but your policy should say that. So you always want to check your policy at the hospice that you work at to see what the policy is for visits when someone's on a different level of care. Documentation daily by the hospice staff and the IPU staff is also very important. And that documentation must have information in it from all three people. So the hospice has to have their documentation, the IPU staff has to have their documentation, and so would the SNF staff if the patient is in a SNF. What I find on a lot of audits for GIP is the hospice is very good about documenting the reason they're going in, what kind of titration they're doing, what kind of medications the patient is on. It's the staff in the IPU, or I should say the SNF staff, that don't collaborate with the hospice about what they're doing and showing that the patient qualifies for GIP. So documentation from all of them must be related to the terminal. So you must, if someone's going in for respiratory distress, you must somehow relate that to the terminal illness. Say what those symptoms are, what the time the medication was given, what effect it had, and what skilled needs are going on. So are you making sure an RN is seeing the patient on a 24-hour period? What kind of symptoms are they experiencing with respiratory distress? What kind of medications were they on before? This is what was on at home, was not working. They were just using an inhaler at home. Now we have them in the unit on, special drips, or we have them in the unit with, special treatments on oxygen with, SVN treatments or whatever is going on. So make sure you're very specific about the skilled need. So when GIP is not appropriate, when do we not use GIP? Well, that is not used when there's caregiver breakdown. When there's caregiver breakdown in the home, we can certainly use respite, but not for GIP. If someone has an unsafe or unclean home, there's different things we do for that. We certainly don't judge a person by the type of home they live in, but if it's unsafe, we have our social worker involved. We may or may not have APS involved and some other authorities, but we certainly don't GIP them for that reason. You may be waiting for placement. Patients in the home and the family decides they can no longer care for them in the environment that they're in, and they're looking at group homes or they're looking at a SNF for placement. Okay, you can't GIP them for that. You must wait for the placement and then put them in there. Frequent falls, as much as we like to put people in an environment where they're watched all the time, this is one of the toughest things I think a hospice nurse has to endure, is the patient has frequent falls. So we recommend for that a couple of things. Obviously, a bed that is secure. If you can have rails on the bed, some group homes don't allow that. Now they're considered to be a restraint. So what we advise you to do is make sure that you have floor mats on the floor, that they have a bed alarm if you can get that through your DME company, and that you also either have a bell or some sort of mechanism to notify the staff and you when the patient is going to fall. And of course, nothing is better than having, someone with them at all times. You will often find skilled nursing facilities asking for sitters for that kind of thing. If the family can provide for that, that's great. Sometimes hospices will send in multiple staff members to check on patients, which is something that can be done. Another frequent request from skilled nursing facilities is, can you GIP someone who is actively dying? It's requiring us to be in there more often. We're constantly doing something in there because they're active. We're giving medications every hour, every 2 hours. Actively dying without symptom management does not qualify for GIP. And I know that sounds kind of strange, but what happens with that is if you have a person who is actively dying and is comfortable, then that doesn't qualify for GIP. And we all know in hospice what that is. So the main thing for that is to make sure that you go into a skilled nursing facility and you're teaching the staff there how to care for that patient very well. Imminent death alone, not appropriate for GIP, must have medication adjustments and frequent skilled need. That's what it really boils down to, and that's what the Medicare regulation really focuses on, is having, imminent death people, unless you're adjusting medications quite a bit. If you're just giving them often, no. But if you're adjusting them and you have a frequent skilled need, then you would definitely want to take a look at that. So dues, describe services provided in big detail. So when you're documenting on a GIP patient, make your notes like you're writing directly to Medicare, and they read your note alone. So I used to think to myself, I need to paint this picture. This is the terminal illness. This is the symptoms that they have. These are the things that we're doing for them. This is the education we provided to the facility. This is the anticipated length of stay, especially if I knew that I was going over 10 days and I knew I would have to justify that stay a little bit longer. I made sure that I painted that picture as detailed as I could. And then I would block out some time. I mean, not hours, but I would block out some time to go into the skilled nursing facility, ask to speak to the charge nurse, tell her or him that I wanted to teach their staff, and make arrangements to come in and do an in-service for them so they would know what to expect and how to document. Document the content, what led up to the GIP. Kind of paint the picture of like giving a story. Patient admitted, on September 23rd with respiratory failure, was, doing inhalers and getting all kinds of medication, list of medications. Then on day 3 or 4, went into hypoxia, went into, couldn't keep, O2 sats above whatever on O2, that kind of stuff. So definitely paint the picture and document why this cannot be done in the home setting. Why can't this take place there? So there's a lot of things that have to go into GIP documentation. And I don't know, quite honestly, if some hospices, they find it easier not to do it, so they don't. But remember too that this is a benefit that the Medicare beneficiary is entitled to when they sign on to hospice. So it's important for you to be able to offer those services, especially if they need it. Describe the specific symptoms in detail. The other thing people forget, or I should say nurses forget to do, is what was the patient's responses to your interventions that you planned. So you had your goals set, you knew what you were going to do, the medication's being titrated, this is what was on Tuesday, this was on Wednesday, and every single patient response to those interventions must be spelled out. Don't say in your notes, patient is dying. It is the expected outcome. End of life care is not something that we would write in there in general decline. Those are general terms. While we know what dying is, we know what end of life care, and we know what general decline is, you have to spell those out and paint your picture for Medicare in order to justify getting paid on that claim. So make sure that you're doing that, you're teaching your staff to do that, and that if there is anything that the CNAs are noticing that are different, that they bring that to your attention. Discharge planning for GIP. So remember, discharge planning starts on day 1. So the first day that the patient goes into general inpatient care, you need to start thinking about what the plan is when they're coming out. Do you see them coming out? Do you see them coming in a couple of days? Definitely talk to the physician. Your doctor, your hospice doctor should be involved. Typically, there's a facility physician as well. And if it's a freestanding inpatient unit, there might be a doctor in the unit too that sees patients every day, which is a great service to have. You would want to discharge when symptoms are stabilized, not before. And maybe you're discharging them from the unit. They're not going to go home now. Maybe they're going to go to a group home afterwards. So you've got a whole other set of people that you have to teach in the group home setting before the patient gets there. And remember to document every day why the patient is still eligible for GIP while they're on it. Why do they still qualify for that? What kind of symptoms do they have? What are you doing about it? What is their response to it? And then overall, make sure that once they do go to the next placement that they're going to, that you've taught them, and a copy of the discharge planning goes with them as well. So here's the first case of a live scenario that actually happened in Phoenix. A new patient is referred to your hospice at Phoenix Mountain, which is a nursing facility here, with a terminal diagnosis of end-stage Alzheimer's disease. The patient is crying out in pain and is very restless. So this is a patient that has got, terminal restlessness maybe, or maybe just, because of the end-stage Alzheimer's disease, is crying out in pain, but happens to be in a nursing home, is not, sitting in home with their caregiver. And this patient is on routine home care, in the facility. So you admit the patient, and the doctor orders pain medication, orders morphine and Ativan for the restlessness, and sleep medication. So the facility wants you to place this patient on GIP. Naturally, facilities want you to do that because they're giving, medication to them for the restlessness, the sleep medication. You're going in there to see them, maybe once, twice a week. You're probably going to have to increase your visits. Do you consider doing GIP? Think about that for a second. What do you tell the facility? You have to think about what your answer is going to be. So you admit the patient, you go back on day 2, and the patient's the same. They're still crying out in pain. So are you thinking you're going to go to GIP? But then when you're checking the MAR, medications in the facility, and you adjust the meds, you find that the facility did not give the meds as ordered by the hospice. So maybe they were ordered every 2 hours, and maybe they were ordered PRN, and they just didn't give it because they didn't think they had to because it was PRN. So what do you do then? So think about that. Do you just go ahead and educate the family about, what's going on there? You talk to the staff in the facility about it, and then you think to yourself, okay, I'm not going to GIP just yet because the medications have not been given as ordered. I'm going to change the medications to hourly or every 2 hours with the physician's approval, and then I'm going to monitor and see if there's a change in the patient now that the facility knows what they're supposed to do, or maybe now they're doing what they're supposed to do. So you want to think about that before you jump into GIP right away. Another patient referred to hospice from a hospital. It's a hospital patient with cancer of the breast. It goes home on pain medications. On day 2, patient still in pain, requiring a change in medication, and the husband is not sure how to give the medications. So this is something that might be a good consideration for GIP, but let's just see where this goes. So you try to teach the husband, but you're not confident that he can pull this off at home. He's too anxious, patient is restless, and now has terminal restlessness. So that would be an indication, he's too anxious, he's not going to be able to do this correctly. The patient is really suffering, has terminal restlessness, which is extremely common. They tend to wander around. They tend to get agitated very easily. You're going to have to give Ativan anywhere from 0.5 to 2 milligrams. You're looking at things for, anxiousness, restlessness, and also for pain. So this might be a good time to consider looking at GIP. So now we're going to go into respite care. Respite is used a lot more than GIP, used a lot by hospices. It's primarily to provide respite care when a caregiver needs a break. So they've been taking care of their loved one for an extended period of time, and maybe they need to go to a wedding, a funeral, whatever, or they just need, to sleep for 5 days. So respite is only for 5 days, as determined by Medicare. That's what the regulation says. Now, I will tell you a side note to this. Just 3 days ago, 2 senators proposed a new proposal to the House of Representatives due to COVID and everything that's going on with COVID, that respite be offered to hospice beneficiaries for 15 days in their own home, instead of going to a licensed facility. That has not been approved. It's just been proposed by 2 senators. Exactly how that would work in a home setting, I'm not sure, because they didn't really spell that out, but that is something that Congress is taking a look at just through the COVID pandemic, because a lot of caregivers are saying that they need more time to get some rest in order to take care of their loved one. But for right now, respite is only for 5 days. It must be provided in a Medicare certified facility. So you need to do that only in an IPU setting or in a skilled nursing facility that is Medicare certified. And remember too, you must have a contract with those particular facilities. You just can't put them in a place that has Medicare without having a contract. Sometimes a facility will give you a contract if you don't have one, especially if it's a patient of theirs and they don't want the patient to be moved out of their bed. So that's something that you might want to take into consideration. So in order to qualify for respite, the patient must have a caregiver. The caregiver also not able to meet the safety needs of the patient, then respite is also allowed. So if the patient is, has a caregiver, it's an unsafe situation, but the caregiver is unable to provide those safe needs, then you can do that for a 5-day respite. So you have to remember there's a lot of different reasons why a caregiver breakdown can occur, and safety could be one of them. Respite is not allowed for placement issues. So if a caregiver says they don't want to take care of them anymore, they want to place them, the social worker for your hospice should work diligently with the family on taking them to see group homes, finding group homes for them, or maybe a SNF or wherever they might go to. A patient can go from GIP to respite. So maybe they've been GIP in a facility and now there's a caregiver breakdown at home when they're ready to come out. You can flip them over to that. An example would be someone's GIP, the caregiver is ill when the patient is ready to go home, therefore respite could be used in that situation. How often can a patient go respite? That's a question I get asked almost all the time, every month, every year that I've been doing hospice. There's no defined amount of time per benefit period listed in the Medicare hospice regulations. But let me just say this about that. If you are doing respite frequently in a benefit period, that becomes a red flag to Medicare to look at placement. Maybe you've got a caregiver that's struggling caring for their loved one. They need a break, they go respite, they go 30 days go by, they go respite again. They're really struggling with taking care of their loved one. If this becomes very frequent, then you might want to take a look at maybe the patient needs to be placed. So that's something the social worker definitely needs to be talked about. And keep in mind too, for GIP and respite, you should always be discussing this at your IDG conferences that you have with your team. It can be done more than once in a benefit period, but if it's a lot, then we're looking at placement for a patient. It's a red flag to Medicare if respite is done a lot in a benefit period. And I can't think of lots of situations where that occurs, but it does tend to occur with some families more than others. So make sure you're definitely aware of that. Must document respite just like you do GIP when it's needed. Why the caregiver needs a break. What is the caregiver situation? I've seen all the time in documentation, care level change to respite. The notes don't say anything about it except the patient went respite. and is there for 5 days in a facility. Doesn't tell me why, doesn't tell me what the caregiver situation is. So it's very important that you continue to document on your patient even when they're respite in a facility. Patients in a SNF typically are not eligible for respite. And the Medicare, the reason for that is they live in a SNF, that's their own home. They're on routine home care, and then all of a sudden they're going to go respite. They don't have to because there's caregivers in the home. The caregivers in that facility, skilled nursing facility, are the nurses, the CNAs, therapists, all kinds of people. So there's no reason to put someone respite in a facility that lives there. You cannot provide respite in the patient's own home they live in because it's not a Medicare skilled facility. Although, if this new COVID thing that they're looking to pass temporarily, the senators have said that they would like to provide respite in someone's home for 15 days. I'm not quite sure how that would work. They would really have to promote that and talk about who the caregivers are going to be. I will tell you that the American Hospice Associations all across the country, and NHPCO, the national ones, have endorsed this bill. So we'll just have to see where that all goes. You cannot do it routinely. If you do respite routinely, it looks like inducement. It looks like that you're typically putting people in skilled nursing facilities all the time for no caregiver breakdown, and you're going to be paying the facility. The state of Arizona, the way that works is we pay the nursing facility a fixed amount per day, and we in turn receive a fixed amount from Medicare per day. It's different from state to state. So if you're listening to this program and you're not from the state of Arizona, you will know that in your state you would need to check how the payment works for respite and GIP in facilities. If there's no caregiver, there's definitely no respite. Frequent respite indicates a problem and must be looked into. Sometimes I'll say to the team at Patient Care Conference, gee, we've done respite quite a bit for this family. What's going on in the home there that they need respite all the time? So I will definitely, ask about that. Visits made by staff should be strictly on patient needs. I do recommend that your policies say for GIP that you visit daily. When someone is respite, it's also considered an inpatient setting. You should need to do that as well. And I think you should definitely keep track of what's going on with your caregivers. Do they get the break that they asked for? When are they coming back? Things of that nature. So now we'll take any questions that anyone might have. We have about 15 minutes left. So are there any questions that anyone has? There's a chat box that you can definitely put into your question, and I'll give it a few minutes for that. Allison, if you could check the chat box, that'd be great.
Awesome. Thank you so much. So we'll give it a couple minutes to wait for any questions. I do have a couple lined up for you, but before that, okay, I do want to take a second just to thank you for taking the time to share this information with us. You did a wonderful job. Okay. And then I want to thank all the attendees for taking the time to join us as well. So now to get into some questions for you. The first one, how long is too long to have a patient on GIP?
That's a very good question because I get that a lot too. Typical short term, 7 to 10 days is your typical stay. Having said that, not every patient is the same. You can certainly justify more time in general inpatient setting for what you need, provided that your documentation backs it up. Whether it's medication titration, symptom management, can't quite get them there yet, working on this, working on that, you can justify it. But if you're going over 10 days, 15, 20, and you've got nothing to back it up, that is definitely open to a problem for sure with an audit.
Okay, thank you. Next we have, what happens if a patient stays on respite for more than the allotted 5 days?
Well, hopefully you've had that worked out, that the family understands it's only for 5 days. There have been situations where the caregiver needed some extra time, and typically what we tell them is you're going to have to pay privately for that probably. We're not allowed by Medicare law to pay the facility more than 5 days. If you don't have your transportation arranged on day 1 and then to get them out after 5 days, you cannot go back and pay that facility for extra time. So you're going to have to eat that cost. But what you can do is you can make arrangements for the patient to stay in that facility with some other method of payment, whether they have, family that's going to pay, they're going to pay privately, or they have some sort of insurance or long-term care insurance, whatever they're going to do, but you have to flip them over to routine home care, get permission for them to stay, and then make other arrangements for that. But you cannot go over the 5 days.
Okay, gotcha. Thank you for that. Then we have, does Medicare require that all hospice staff visits patients that are on GIP every day?
No, they don't require it, but it's recommended. So as I mentioned before, I would definitely say, look at your policy. If you don't have a policy about GIP and respite, you really should. And I think, policies are open to interpretation. They should be looked at every year. You should have a special IDG group of people that look at policies. Your executive director and your clinical director and the nurses are all very important people to talk about policy. And I think if you, think that something should be changed or recommended, you certainly should have a voice in that. But Medicare leaves that particular situation up to the individual hospice to determine what their frequency should be. I will say this though, if you don't go in routinely when someone is GIP, it looks like abandonment to Medicare in my eyes. You have not followed up and kept up with your patient and their needs. So make sure that you're looking at everything when you look at a policy.
Okay, and then the last question we have for you is, can respite care be done in a group home?
No. The reason is because group homes are not Medicare certified. Remember, the regulation specifically says that respite and GIP be done in a Medicare licensed facility and one that you have a contract with. Who knows? That might change, up the road in several years to come. But for now, group homes are popular in certain pockets of the country. They're very popular here in Arizona, whereas New York, they don't have very many group homes. They typically use skilled nursing facilities. And one of the things that a lot of states do, a lot of hospices do in different states, is they have designated inpatient units in hospitals. You can contract for a group of beds. That's a very, lucrative thing to do. And several hospices, you work out a deal, a contracted arrangement with a hospital, and you have your own freestanding unit right there. I've had several of those in my career and found that to be very good for patients that are on hospice. So I would definitely recommend that you look at all your options, but it must be a Medicare certified facility.
Okay.
Is that
So
it?
that's all we had. Thank you again for taking the time to share this information with
Sure.
us.
I just want to close out with one thing. Just remind everyone that this is a webinar series. We typically have Arizona Care Hospice has webinars every month, usually towards the end of the month. The next one coming up is on the dying process. That'll be the end of October. In order to register for that webinar and all of the webinars that we have, go to www.azcarehospice.com and you can register for all of them. In addition to that, when you go to that website, you'll be able to see all the recorded ones that we've done that maybe you've missed. So you certainly can do that as well. And then we also have other things on the website, discussions that doctors have with patients, people, families, open forum discussions, podcasts, all different kinds of things on there. So feel free to browse through the website, and there's multiple avenues for education as well. Anyway, thanks for joining us and hope to see you again next month.